Hi, everyone, and welcome to the Wise Body Podcast, where we talk about eating disorder recovery and all things body. I'm your host, Dr. Sarah Hughes. I bring 20 years of experience as an eating disorder therapist, and I've worked with hundreds of clients to feel more empowered and connected to their body by tapping into the wisdom it holds. I'm so excited to keep learning with you as we navigate the windy path that is recovery. So let's get started. Hi, and welcome to the third episode of the Wise Body Podcast. I'm Dr. Sarah Hughes. Today, I thought I would come on and review the 5 levels of eating disorder treatment and 5 of the most common myths that I hear about eating disorder treatment in my practice. As you all know, I love debunking myths about eating disorders, so I thought I would sprinkle some in this episode. But first, I wanted to share that I often get asked to give recommendation for level of care, even in the first consultation in meeting with someone. And I like to walk clients through the levels of care, even besides the one that I am recommending, so that someone knows what to expect, whether they need to step up or step down in levels of care. I will provide rationale for why I am recommending that level of care. I think it's really important for clients to be informed the reason why I am recommending what I am. So let's dive in. The highest level of treatment or most restrictive is called inpatient or hospital level of care. And that's exactly what it is, exactly what it sounds like, going to the hospital. And so this really does indicate a high medical risk or life-threatening risk. And I'm going to talk about some reasons why I might recommend inpatient. One would be labs. So I know that I talked in the first episode about labs being just a piece of the puzzle. But if you have labs that are really out of range, really critically low, for instance, you might be recommended to go to the ER right away, because often that means that your heart is at risk. When you get labs drawn, you will commonly get like the comprehensive metabolic panel, the CBC, right? Complete blood count with differential. We also look for electrolytes, sodium, potassium, magnesium. If there is an electrolyte imbalance, that can lead to cardiac arrest. So we want to be very careful with your electrolyte levels. We definitely want to look at those. We also look at phosphorus and glucose levels. We test for liver, kidney, and thyroid issues. So with your thyroid, you may have heard of T3 or TSH. Those are some common labs that we might run. And side note, when you are in treatment, these labs might be run weekly. Maybe the whole comprehensive set of labs, or there might just be a few if there are a few that are being monitored closely. So if you have critical lab values, it might be an emergency. You might need to go to the ER so that your heart can be monitored. You may or may not be admitted, but it's good to get checked out at the hospital. And the thing about the hospital is that they have the equipment. If they need to do a quick EKG, for instance, or any other test really that they can run in the hospital that you can't do at like your outpatient doctor's office, they can do it all. But labs is just one thing. I mentioned EKG. So if you have an abnormal EKG that is significant, that your doctor's worried about, of course, they would recommend you to go to the hospital. Things like low resting heart rate, that's called bradycardia. It could be 30s, 40s, 50s. That's concerning. Or something called tachycardia, which is higher rapid heart rate that may be detected even with like minimal exertion. So like even walking across the room or from sitting to standing and your heart rate jumped, say like 20 points, that's something really significant. And that just means that your heart is under a lot of stress and having to work really hard to function. You may or you may not feel lightheaded, with heart issues. So that's why it's important to get blood work done and your vitals done. Also things like having a low blood pressure, so something like 70s over 40s, that's concerning too. An EKG I mentioned is good for picking up arrhythmias. So if your heart's skipping a beat or there's some kind of murmur, those are things to look out for. Heart muscle atrophy. Your heart is a muscle, and if it starts if it atrophies, if it starts dying, that is really important to get checked out because you can die from cardiac arrest. And again, these are things that the hospital can tend to and can hook you up and monitor you and can do that for long periods of time. So if that's needed. Of course, if you are suicidal, that might also warrant an inpatient level of care. So if there is intent, if there is plan, it may be recommended to go to the hospital as well. Also during the refeeding syndrome. So there's something called refeeding syndrome, which is when you are going through the process of restoring weight or just in general, just the nutritional rehabilitation period. There can be some complications related to fluid or electrolyte shifts, which can lead to death. And so if you are at higher risk of refeeding syndrome, whoever's assessing may recommend that you go to the hospital to be monitored for refeeding syndrome. Of course, if you need a feeding tube, or it's called an NG tube, most residential settings, which is the next level down, don't have NG tubes. Only hospital levels of care do. So those are the common reasons why someone might need inpatient or a hospital level of care. And if you're thinking about a hospital, it's exactly what you're imagining, right? It's a hospital room. There might be 1 or 2 beds. You might have a roommate. You might be in bed most or all of the day, especially if you are at fall risk. It is not exhilarating. It is probably quite boring. And there's often not a lot of therapy happening. And the reason for that is because the priority is saving your life and not necessarily processing in therapy. Also, when you need that level of care, the brain is often undernourished as well. And so it's hard to maybe focus or make connections or make sense of things. And so therapy isn't necessarily a good idea in the hospital anyway. But you will have a comprehensive care team that will include a therapist, a psychiatrist / MD, a nurse, a nutrition therapist, social worker / therapist. I don't think you would get both, but you will have a team and they will meet with you pretty frequently, sometimes maybe even every day just to check on you. But your weight and labs and vitals might also be done more frequently because they can. Hopefully at the hospital level of care, it's a brief period of time. And then you can, once you are medically stable, can move on to the next level of care, which most often people step down in levels of care. Sometimes if you jump, you might jump a level of care if it's warranted. But today, for the intents and purposes of reviewing each level of care, I'm just going to go in order of most restrictive to least restrictive. So the highest level of care is inpatient or hospital level of care. The next level down is residential. And so that is 24/7 care, similar to a hospital, but some of these residential programs, it's like a house and they have dorms. And so it doesn't feel as medical, I would say. It doesn't feel as much like a hospital. And this level of care is really focused on having a group therapy format with nutrition rehabilitation. So someone is really relearning how to eat, and all of the meals and all of the snacks are provided at the residential level of care. You may have some choice in your meals. So sometimes a nutrition therapist might present menus and you can make choices. Of course, it's encouraged to just choose preferences rather than listening to your eating disorder, make the decisions about what you eat. And if you have celiac disease or if you are lactose intolerant, they will likely require documentation of those. because that's something you would need to restrict from your meal plan. And they really want to make sure that there is a good reason for that. And that it's, again, not your eating disorder deciding what not to eat. I hope that residential settings will try to honor your preferences, but sometimes it gets a little tricky, right? Like, is this your eating disorder making this choice? Or are you making this choice? And I think part of the residential experience is coming back to yourself and coming back to what do you like rather than the eating disorder deciding. And I often hear like, I don't like that food, but really that might be more of a challenge food. It might feel like a really scary challenge food, like the highest on we call them like a fear hierarchy. So if you think of like the scariest food, level 10, right? But is that really something that you don't prefer? Or is it the eating disorder telling you that it's not okay to have? And so really trying to explore and get back to food freedom and what you really like and don't like, I think would be a really good goal for residential treatment. So also things that are monitored in residential, weights, vitals, those are usually done every day, like at a nursing station. Labs are done as needed, but can be done there or done and then sent out. And that really just depends on what you might need. But in a residential setting, as it sounds, you are living there and you might be kind of far away from home. So that can be kind of hard, especially when visiting hours might be like an hour or two, like in the middle of the day or in the evening. So keeping that in mind as well. I often get asked about like rules for residential. So like, what can I bring? What can I not bring? Every program has their own protocol, and they will likely send you a list of what you can bring and what you can't bring. You might be able to bring your cell phone, but only use it during certain times. That's really common. But things like perfume or anything sharp that can be seen as harmful, those kinds of things I would leave at home. In residential, they vary in terms of how many residents they have at one time. Sometimes it might be 10, sometimes it might be 15 or 20. It really just depends. There may be wait lists too. So if you're inpatient and waiting for a residential bed, you might need to wait an extra day or two, maybe even longer for a residential bed. It just really depends on where you're going and if that program has availability or not. So similar to inpatient, at residential, you will have a care team that's comprised of a therapist and a psychiatrist/MD. You might have a nurse, probably not specifically assigned to you though, a nurse that might just see everybody and do weights, vitals, labs as needed, and then a nutrition therapist as well. You may see your psychiatrist, therapist, and nutritionist once a week, maybe twice a week. It just depends on the program. So if it's important to you to see your therapist twice a week, that might be something that you ask before you go. The next level down is called PHP, or Partial Hospitalization Program. And I think of this as kind of like a day program. So you're there in the program during the day. And there are some programs that are like 8 a.m. to 8 p.m. A place that I worked in, we called it PHP Light because it was 9:30 to 3:30. So it was a shorter day. It really just depends. But typically they're not running program on the weekends. So it's a Monday through Friday program, either like 8 to 8 or 9 to 3, something like that. In PHP and residential, I really think of those two programs as a place to relearn how to eat. I know that sounds strange, but the eating disorder really hijacks your ability to eat. And so in PHP and residential, the food is provided for you. You may have menus, right, where you can choose what you want, but the food is literally catered. In a PHP that I worked in, I would say like meals are catered. We would order from restaurants every day. And it's actually good practice to eat restaurant food. So in PHP, you may get every meal and every snack provided to you. And by the way, 3 meals, 3 snacks a day is a very typical meal plan, even if you're on maintenance, even if you're just maintaining your weight. In a PHP light program, like I was saying, like a 9:30 to 3:30 or a 9 to 3 program, the expectation would be to have breakfast before program and then arrive at program, do weights vitals, and then have a morning snack. And then you would then usually go into a group, right? Also group format in PHP, and then lunch, and then a group or two, and then afternoon snack. And then the expectation in the evening, if you're in like a PHP light kind of situation, would be to have your own dinner and evening snack at home. And some people may be ready to practice that. And if you are struggling with eating out of program, then residential might be more of an appropriate fit. That's actually a really clear distinction for me between PHP and residential. Like if you feel like you can't eat on your own at home, or you're really struggling on weekends, or you're really struggling in the evening, residential might be a more appropriate fit because of that 24/7 care. In PHP, same kind of care team, if I can't remember if I mentioned. So therapist, dietitian, psychiatrist, typically meeting weekly and not really more than that at the PHP level of care. And weights, vitals, those are done every day. Labs are done with your primary care doctor outside of program. And so if you have a psychiatrist, and hopefully you have a physician, like a regular physician for physicals, we would collaborate with those doctors as well. But it's really necessary that you have your own physician. Sometimes people come to program and they're like, I don't have a doctor. I've been in college and I just go to the health center, or I just go to urgent care when I need a doctor. And that's okay. But I think it's preferred if you have like a regular doctor that knows you, and hopefully that knows that you have an eating disorder, but that's something that your therapist can also explain to your doctor in a collaboration call if you give permission for your therapist to talk to your doctor by signing a release of information. Collaboration of care is so important at all levels of care. Just want to make a side note here. Nutritionists talking to doctors, therapists talking to former therapists talking to your MD, psychiatrist, making sure that your care team in treatment is talking to your outpatient team, because that the plan is that you will return to your outpatient team. And so for everyone to get on the same page and be collaborating and communicating what is happening for you while you're in treatment is really, really important. And I think is often most appreciated by my clients as well. It does take extra time, but it is so worth it and so important. Can't stress that enough. So then moving on to IOP, which is stepping down the ladder from PHP, is IOP, which stands for intensive outpatient. And this level of care is really for folks that are more in maintenance, right? Like they're doing pretty well in their recovery. They might have some slips here and there, but for the most part, they're on this course and they might just need a little bit of support. So in IOP, it's usually like 9 hours of treatment a week. Some IOPs are offered in the evening to really cater to those people that are working during the day. Sometimes people prefer an afternoon IOP. I know at my last place of work, we offered both afternoon and evening because it was kind of split. Like some people liked afternoon, some people liked evening. So we offered both. It just really depends on like what structure is best for you. But IOP, I think of as like a mini version of PHP. And so in PHP, you will get a lot of varied groups, also in residential, right? So you will have skills groups, like if you don't know what these are, it's okay. DBT, dialectical behavior therapy, CBT, cognitive behavioral therapy, right? Those are skills groups. You might have nutrition group, a process group, like a community meeting group. You might have even like a medical group in which the psychiatrist might present medical complications of eating disorders. There are a slew of groups that are offered in residential and PHP. And in IOP, we sort of choose which ones and then have those every week. So we might not have like a nutrition group or a medical complications group, but there's typically always a skills group. So DBT, CBT, a process group, think of like a general support group, and then some other group. So in the last place I worked, it was experiential therapy, super cool. And I highly recommend. It's a very powerful experiential therapy. And maybe we'll have another episode on what experiential therapy is. And I actually have someone in mind, so a guest in mind, and hopefully they can join and share more about that. But you have 3 groups a week, and then like they're on repeat. So every Monday you have a process group. Every Wednesday you have a skills group. And then every Thursday you have an experiential therapy group, say. So it's not as comprehensive in terms of like the group therapy format, but you're getting some really good, solid groups in there. Your care team is a little bit smaller. So you'll have a therapist, a nutritionist, but you will not have a doctor or psychiatrist. The IOP program is really going to encourage that you have an outpatient psychiatrist and obviously an outpatient doctor, and your therapist and nutritionist can collaborate with them, but a doctor is not typically on your IOP team. And the reason for that is, right, that it's least restrictive. And so the idea is that you don't necessarily need as much medical support in IOP. Even though insurance companies often use the term medical stabilization, even in IOP, but there really is not a lot of medical care given in IOP. In fact, your weight is assessed for sure, and vitals are taken, yes, but labs that you're referred out to get your labs, and of course, your medications, as I mentioned, with your psychiatrist. That's not something that's provided in IOP. Also, little meal support in IOP. You might have like one meal during that group time. So let's say if you have like a support group, you might have dinner or lunch in the middle of it and then go back and finish group. But the expectation is that you eat according to your needs, and there is an expectation usually to complete, but it's not really reinforced. And a supplement like a boost or ensure is not going to be usually offered in IOP as they would in like PHP or residential, because at those levels of care, it is really required that you complete 100% of your meal plan. Before I go into the last level of care, which is outpatient, just wanted to talk a little bit about length of stay. And so people often ask me that, like, how long am I going to be in treatment? And the answer is really, we don't really know. It really just depends. So it depends on how you do in the program. Are you sort of meeting the expectations of the program? But also insurance plays a role as well. Fortunately, unfortunately, right? So fortunately, insurance does cover the cost for the most part, which is great in most cases. But also because insurance does cover the cost, they tend to, I say, dictate treatment. And so even if you might not feel like your time is complete in a level of care, insurance might think so. And they're going to stop funding your treatment, and then you may be discharged. And sometimes that happens before you're ready. And that is really something that I struggle with a lot. And I would often contest an insurance company's decision to do that with something called like a doc-to-doc call. So I would talk to a doctor that was affiliated, well, not affiliated with the insurance company. They were non-partial to the insurance company, but provided my rationale for why my client needed to stay in treatment, and they could either agree or disagree with me. And if they agreed with me, then maybe my client could stay longer at that level of care. If they disagreed, then it was kind of like a done deal, because that is really part of like an appeal process. So then the last level of care, least restrictive, is outpatient. Think of this as your regular weekly therapy session with your outpatient therapist. Some therapists offer, more than once a week therapy. And that's really just based on the therapist's level of comfort, okay, yes, I think we can meet your need if we meet twice a week, maybe for a brief period of time. But if you're needing more than that, then you might need a higher level of care. Some therapists just don't have time in their schedule to meet more than once. So it really just depends. But people in the outpatient level of care are really hopefully doing pretty well, and maybe a slip up here and there, but there's a quick time to kind of return to recovery, if that makes sense. Someone isn't like fully relapsing, like staying in behaviors for long periods of time. And your outpatient team kind of looks like your care team in higher levels of care. You may have a therapist, right? A regular doctor. You might have a psychiatrist, a nutrition therapist. You might have a recovery coach. If you're needing a really big team and meeting quite often, that's an indication of maybe needing a higher level of care as well. And it really just depends on who is on your care team when you're outpatient. So I know some folks that are just in therapy. They have a therapist and a doctor and don't have a nutrition therapist, maybe don't need one. Sometimes I have clients that use their nutrition therapist when they need to. Or I have some clients that are like, no, my team is my therapist, nutritionist, psychiatrist, doctor, and that's it. And I need all of those people on my team, and I need to meet with them all regularly. And hopefully, again, collaboration between members of your team is happening quite frequently as needed, right? But hopefully that it's happening so that everyone is on the same page and working with you towards your goals, and that everyone is aware of what you're working towards. It's really, really important. Okay, so let's shift into 5 myths about eating disorder treatment that I most commonly hear in my practice. I referenced one a little bit. The first myth that I have that I referenced a little bit was it's going to just take, treatment's going to take 2 weeks and then that's it. So again, we really don't know. We really don't know how long you're going to be in treatment, and it really just depends. So things like if you have a lot of weight to restore, or if you're really far away from eating regularly and enough, if you are engaging in binging and purging frequently, then these cycles are really hard to break, then you might need to be in treatment at a high level of care for a while. Sometimes what I like to tell my clients is that, hey, let's get you in the door. Let's give it 2 weeks and reassess. And I really want to make sure that my clients hear me, that I'm not saying, yeah, 2 weeks and you're good. But let's commit to 2 weeks and then let's talk about it. And your care team is doing that very frequently with you too, checking in with you. How are things going? How are you feeling? How are you doing? Do you feel like you're meeting your goals? And your care team is, of course, going to use the word weigh in on that as well. So yeah, it really just depends. And then, of course, insurance plays a role as well, as I previously mentioned. Second myth, treatment is like jail. So I will say that a hospital unit does have some locked doors, so that can kind of feel a little jailish, but it is not jail, especially if you are older than 18 and you are the medical decision maker, then treatment is voluntary. If you are younger than 18, your guardian parents, they're making the decisions about your medical care. And I think that's really important. And then I think that's really important, as it feels like you don't have autonomy. And you might really not if you're 12 or 13, right? Or younger than 18. Or if someone is legally making your medical decisions. Sometimes people go to court to assume that responsibility, right? So it's not jail. You are not sentenced. You didn't do anything illegal. But it might feel very, very restrictive because of the medical risk. So I think hospital settings kind of tend to get that rap, if you will. And residential programs might like lock their doors at night or when it's during non-visiting hours. And that's just really a safety thing as well. Same with PHP and IOP as well, locking like the front door. The third myth is I'm going to miss out on my life. So treatment is part of your life. School, work, friends, they're all going to be there. But this is very much life happening. And although treatment is hopefully considered like a safe bubble, it's not reality. And so I really encourage my clients to be as present as they can to get the most out of treatment as they possibly can. And that returning to work and school is something that they can do after. Something I do a lot for my clients is write like a letter to school excusing someone for medical reason to attend treatment so that someone can take like a medical leave. Some places of work also offer medical leaves as well. So those are some things to maybe look into and to try to reduce the barriers. So things like, I have a dog. Who's going to take my dog? This is your life. It's really important that you preserve it, right? And so trying to find someone to take care of your dog, trying to find someone that can check in on your house or your apartment to make sure that the pipes don't break or something like that. But, treatment, if it's needed, it kind of trumps everything. And it's really important to do it now if you can and not delay so that your eating disorder doesn't get worse. So that is the risk if you delay treatment. Myth 4, so I hear this a lot, which is if I go back to treatment, I failed and I'm like starting all over again. So how I respond to that is if you've been in treatment before, you are forever changed and you are not the same person. So if you go back, you are a different version of yourself going back in, and you might know more about what to expect. And so there's absolutely like no way that like you're going backwards. That like defies science, really. So I like to think of clients as you've been changed by treatment and you can be changed again for the better. And for it not to feel so much like a failure. But I know a lot of folks do have that sense of shame going back into treatment. But eating disorders have such a high relapse rate. We see a lot of the same folks come back to treatment, and that's okay. It just means that you need it. And sometimes maybe you need like a lower level of care just to kind of get a boost. But sometimes you might have like fallen way back into a relapse of behaviors, and that's okay too. It really just depends on what you need. And then the last and final 5th myth today that I wanted to share is one that I shared in the first episode, which is I'm not sick enough. Like I'm fine. I'm getting straight A's. I'm working a 9-to-5 job. I'm caring for kids. I'm caring for my house, right? Like I'm okay. Like I'm super high functioning. So that's all well and good. However, if you're engaging in an eating disorder, your body really is sacrificed and it is really struggling and it's trying maybe even extra hard to compensate to be able to function at such a high level. And so getting straight A's doesn't fool me because if I know that you're engaging in eating disorder behaviors, that really is most important. And I take that like really seriously, more seriously than getting straight A's is your health. Kind of paired with that is, the sick enough idea that Dr. Gaudiani wrote about, she wrote a whole book about it, is I don't want to take someone else's spot in treatment. They need it more than me. And that's not necessarily true. Everyone deserves treatment. But when you start getting into comparing, which a lot of eating disorders like to do, it can lead to not feeling like you deserve it. And I just want to say that everybody deserves treatment and it can really, really help. So I will end here for today. And please, as always, if you have questions, please send them my way. My email and website are in the show notes. Thank you so much for listening.
Thank you, everyone, for taking the time to listen in this week. I'm so glad you're here with me as we learn more from our wise bodies and about eating disorder recovery. For more, follow me on social media, and please share the Wise Body podcast with your friends. Lastly, if you're interested in a free client consultation, please reach out on drhughes.com. And remember, always take care of yourself and your temple. See you next time on the Wise Body podcast.